Hello and welcome to EHJ Today. My name is Stefano Taddei and I am Professor of Internal Medicine at the University of Pisa. We are speaking from London, from the annual meeting of the European Society of Cardiology, and it's my honor and privilege to introduce you Professor John Gorcsan from the University of Pittsburgh. Is Professor of Internal Medicine and is the Director of Echocardiography, and Professor John Cleland, who is Professor of Clinical Cardiology at the Imperial College in London. The topic of our discussion will be the CRT trials. So, first, John, can you describe us the previous results of this trial?
Yes. So, the EchoCRT trial was an interesting randomized trial of low ejection fraction heart failure patients. Almost all of them were New York Heart Association Class 3 with a narrow QRS width that was defined as less than 130 milliseconds and echocardiographic desynchrony. So what desynchrony means is that one part of the heart mechanically activates earlier than the other part. So it's sort of like a delay. Typically the septum's early and the lateral and posterior walls late. So they selected these patients based on this echodesynchrony and narrow QRS to test a hypothesis that these heart failure patients would benefit from CRT. And actually the results, it was a negative trial. There was no benefit with respect to the primary endpoint, which was a combination of heart failure hospitalizations or death. And surprisingly, there was an increase in the total mortality in patients treated with CRT. So that led to us to think something very different. What does mechanical desynchrony mean in patients with a narrow QRS?
Okay, and basing on the previous results, what are the results that you obtained in the sub-study that you presented yesterday at EHJ, and they are being published in European Journal?
Yes. Yes, thank you for asking. So this sub-study consisted of patients with follow-up echocardiograms. We had 614 patients that had an echocardiogram at 6 months. And it was equal in the CRT off and the CRT on group. And we tested the hypothesis that this mechanical desynchrony was a marker for poor clinical outcomes. So in these patients, we looked at, first of all, does the desynchrony associate with clinical outcomes? So with the primary endpoint, which was heart failure, hospitalization, or death, that was highly statistically associated with more events. So it's really interesting. I want to say that at 6 months, about 25% of the patients in both CRT on and CRT off groups had improvement in desynchrony. Very interesting. I could come back to that. We don't know exactly why. I have some ideas. But the patients who improved their desynchrony had less heart failure hospitalizations and combined with death, less. And then we looked for an association with the CRT treatment, and we saw no interaction statistically. So it appeared unaffected by CRT. And it didn't matter if we used the tissue Doppler method for desynchrony. That was associated with heart failure hospitalizations. If we used speckle tracking radial desynchrony, that was associated with heart failure hospitalizations. If we looked at an increase in desynchrony by either method, that was also consistently associated with an increase of heart failure hospitalization events.
Okay, perfect. And John, the other John, would you like to comment these results?
Yeah, I think EchoCRT has been a very helpful study in terms of clarifying the guidelines and the importance of assessing QRS duration. Intriguing results. I think when we look at desynchrony, one of the big problems that we have is that some of this desynchrony, especially in the ischemic heart disease population, is going to be due to myocardial scar and fibrosis, and some of it is going to be dysfunctional myocardium, but still viable myocardium. So we have this interaction between desynchrony and viability. And I just wonder whether the response to CRT, or indeed the improvement in both groups in this study, indicates that there's viable myocardium. We know that beta blockers, for instance, it can take a long time for the impact of beta blockers to fully appear in this dysfunctional myocardium. It can probably take a year to 18 months before you see the full effects of a beta blocker. So it may be that, and it would be interesting to look at the stability of the pre-randomization pharmacological therapy and whether there was continuing pharmacological improvements in both groups, reduction in myocardial viability, and this improvement in function indicates viable myocardium, less scar, and is naturally would then be associated with a better prognosis. There's one other sting in the tail, and that is we've looked at it again and again with meta-analysis in these large clinical trials, and ischemic heart disease is not doesn't determine the impact of CRT on prognosis. We know that the patients with ischemic heart disease have worse outcome in the control group and in the CRT group. The change in prognosis that CRT makes is etiology independent. So we know that CRT is less likely to improve the ventricle of somebody with ischemic heart disease, and yet it doesn't diminish the benefit of CRT on outcome, and that implies that there's something other than ventricular function at play here. And I'm a big believer that atrioventricular resynchronization is important, reduction in mitral regurgitation is important, and also prevention of bradycardia is important. Won't see that in a CRT-D versus ICD trial, but in CARE-HF and Companion, where we were comparing device versus pharmacological therapy, it may well be prevention of bradycardia is an important aspect of these treatments. And that then leads to the added complexity that CRT is probably working in different ways for different patients and at different times. And that makes prediction of benefit very difficult, and surprising that QRS helps us so much.
Okay, perfect. So, based on this last issue raised by John Cleland, John Gorcsan, what is the take-home message for our colleagues and clinicians?
Yeah, so I'm delighted to respond, and I agree with John Cleland that as he has stated now and in a few eloquent editorials, that we still have a lot to learn about CRT. It is a powerful therapy that can benefit our patients in so many ways. EchoCRT taught us that we really don't understand this mechanical dyssynchrony, and there's a potential for doing harm. I do agree what my principal hypothesis why the patients improved was pharmacotherapy, in that 97% of the patients were on beta blockers, and 95% were also on ACE inhibitors or ARBs. And this was, I think, cumulatively contributing perhaps. And I think we still need to understand how much of an electrical delay, how much of a mechanical abnormality is needed for CRT. I think the guidelines which focus on the very wide left bundle branch block are perhaps a safe bet, but we still are not focused enough on the patients in the middle, the intermediate QRS that we can benefit. And I think helping define the electromechanical substrate is a hope for the future.
Okay, and John Cleland, your last comment and conclusion?
Well, I think that I'm interested in trying to understand the QRS better, because the QRS is the strong biological signal here, and the strong mythological signal as well, because we've got this running through all the guidelines, really not evidence-based. It's a post hoc review of the data, which is that QRS morphology matters. We've done the 12,000 patient now, individual patient data meta-analysis, and QRS morphology doesn't matter. It didn't matter in the Medtronic trials, individual patient meta-analysis. It doesn't matter in the taking all the clinical trials together. Once you adjust for QRS duration, QRS morphology doesn't matter, and yet it's there sitting in all the guidelines like a toad, and we really need to do something about this problem that we have with the guidelines, which I think are just misleading.
Okay, John, thank you very much, and enjoy your stay in London.
Thank you.
Thank you.